On yet? Ready? Good morning. Dental aesthetics. I've given this seminar for over 30 years. And usually it's a 2-day seminar. So this morning I'm going to try to condense the basics of the fundamentals of aesthetic dentistry into about an hour. So obviously I'm not going to cover the whole thing, but I want to go through the fundamentals. Because what I find today with the new wave of dentistry is that dentists really don't seem to understand the fundamentals of aesthetics or occlusion. It's just kind of gone away. And that's like being a home builder and not knowing the fundamentals of a foundation. So I don't really know what exactly has changed, but I'm going to try to give you with the Center for Aesthetic Restorative Dentistry and our dentistry master classes and YouTube videos, I'm going to give you the fundamentals of these things. Because if you don't know the fundamentals, it's really difficult to do the basics. So this is the recipe for the perfect smile. My coach in high school used to call this skull drill. What are you thinking about? Well, these are some general checkpoints. You begin with the correct length of the maxillary central incisors. Then you determine the lips in repose classification. I'm going to talk about that in a minute. There should be some tooth display with the lips in repose. There's several ways to determine the optimum length of an individual patient's central incisors. The incisal plane of the maxillary central incisors should be parallel to the pupillary line. It means the pupillary line, line drawn between the pupils, is parallel to the floor. So the incisal plane of the central incisors should be parallel to the pupillary line. We'll enhance that thought here in just a minute. The incisal plane of the maxillary anterior teeth should be parallel to the lower lip and the gingival line. So some of the basics of the fundamentals of cosmetic or aesthetic dentistry are you want a line drawn between the pupils to be parallel to the gingival line approximately, the incisal plane approximately of the maxillary anterior teeth, and the lower lip. All those should be parallel, and I'll go through some cases here in a minute. The midline, the maxillary central incisors, should be perpendicular to the pupillary line. So if this is the pupillary line, which is parallel to the floor, in a perfect world, the line between the central incisors should be perpendicular to that pupillary line. Now, midline is of little consequence. I'm going to talk about that in a minute. The ideal incisal plane of the mandibular incisors is flat. You'd rather not have a U-shaped or an arced plane of central incisors. That's not as aesthetic as a flat plane from lateral incisor to lateral incisor. The cuspids are always a little bit longer, but you want the incisal plane of the mandibular central and lateral incisors to be flat. And then you want the ideal hue, chroma, and value of the restorations. And that's a thought right there. I could give a half-day seminar on that. How do you decide on the shade? The hue, chroma, and value. We've got a lot to talk about this morning, so I'll get going. The first thing we need to understand is the tooth size. The ideal central incisor on a normal person is about 10 to 11 millimeters long. And it's about 8.5 millimeters wide, or about 9.5 millimeters wide. So the central is about 10.2, actually it's about 11 millimeters long and about 9.5 millimeters wide. The incisal plane should make a U, like a banana or a quarter moon, and that incisal plane should be approximately parallel to the lower lip. the incisal plane of the centrals should be parallel to the pupillary line. These are different incisal planes, but you always want the centrals to be the longest teeth. And depending on what the objectives of the patient and how you visualize the patient, a very sexy look is really dominant central incisors, significantly longer than the lateral incisors like this. So the incisal edges, you want the centrals to be the longest teeth in the arch. The laterals are a little bit shorter, and the cuspids are approximately the same length as the centrals. Now they'll look a little shorter because the incisal plane moves up as you get to the cuspids, and then the cuspids join the occlusal plane. So you don't want a big step between the cuspids and the posterior teeth. You want it to kind of blend like a horseshoe. The interproximal contacts are not at the gingival part of the tooth, of the anterior teeth. They're in the incisal third. The zenith, or the high point of the gingival line, is in these areas. The longest part of the cuspid is about right here, the lateral here, centrals here. So they're not right in the center of the tooth. The zenith, or the arch of the gingival line, is on the distal part of the tooth. And the gingival line, as we said, the gingival line on the lateral incisors is always a little bit lower or less apical than the gingival line on the centrals or the cuspids. So it depends on what you're looking for. If you're looking for a very sexy tooth, then the centrals will be significantly longer than the adjacent teeth. If you want character, you can have some roughened edges, or you can make it wild. Depends on what your objectives are. Then the tooth form is significant. You want a little indented part right here. Light refraction and reflection has a lot to do with the natural look of restored teeth. So you don't want a flat surface because if there's no anatomy in the surface of the tooth, the light will bounce straight back and it'll look unaesthetic, it'll look unnatural. So these are the inverted areas. You always want some differentiation between the teeth. You'll notice someone that's older that hadn't worn a night guard, they grind their teeth, all the anterior teeth will be the same length because they've worn them down. That's why I'm such a fan of a night guard. For girls when they're about 16, and for boys when they usually reach about 22 and they've stopped growing, because almost everybody grinds their teeth and they brush their teeth at night. If you start looking at people's teeth, you can normally tell the side they sleep on by the wear of the anterior teeth. If they sleep on this cheek, they kick the jaw up to the left, and the incisal plane will go like this. If they sleep on the left cheek, the jaw goes up like this, and the incisal plane will look like this. So, to me, almost everybody ought to have a night guard when they quit growing. Girls at about 16 and boys at about 22. Lighter teeth appear larger and closer to you. So if you fabricate restorations that are lighter than the original teeth, they're going to look larger and closer to you, even if they're the same length. Important aesthetic concepts. The maxillary central incisors should be longer than the lateral incisors and cuspids. This is a pretty ideal smile. What do you like about this smile? The incisal plane of the central incisors is parallel to the pupillary line, which is parallel to the floor. The centrals are the longest teeth. If you measured those centrals, they're probably 10.5 to 11 millimeters long, which is the ideal length of central incisors. And then the incisal plane of the anterior teeth mirrors the lower lip line. There should be tooth display with the lips in repose. I'm going to go over that in a minute. We're going to talk about the 3 different types of lips and the way the anterior teeth approximate the lips. But you also always should have tooth display with the lips in repose. If you don't, it makes the person look like they have no teeth. Ideal midline is of almost no aesthetic consequence, meaning the midline being in the middle of the face. Studies have shown that a regular person doesn't notice a midline being off-center until it's about 4 millimeters off. And even dentists and orthodontists don't notice it until it's 2 to 3 millimeters off. And certainly aligning the midline of the maxillary arch with the midline of the mandibular arch is of zero consequence. I'm talking zero. So you want the contact or the line between the central incisors to be perpendicular to the pupillary line, but being in the center of the face is basically of little importance. The ideal smile displays the free gingival margins of the centrals along with 9.5 to 11 millimeters of central incisor tooth structure. So in a perfect world, when a person smiles, you see the entire tooth and maybe some gingival tissue. But if you want your teeth, the patient's teeth, to look the same when they're 70 as when they're 15, give them a night guard. Watch my video on how to keep your teeth for a lifetime, and I go through those things. The average central incisor is 11 millimeters in length from CEJ to incisal edge. So think about it. That's what we're looking for when we're restoring people. You want the central to be approximately 11 millimeters long. You want the central incisors to be the longest teeth in the anterior part of the mouth. You want them to be a little longer than the laterals and the cuspids. But if people don't have a night guard, as they get older, they wear the teeth so that they're all the same length and they look old. So give them a night guard. The gingival border of the anterior and posterior teeth should be symmetrical and parallel the incisal and occlusal planes, meaning you want the gingival line all the way back to the posterior teeth to approximately parallel the incisal plane and the occlusal plane. You want it to look like a horseshoe. You don't want a big step between the cuspids and the posterior teeth. The maxillary incisal plane should parallel the lower lip, gingival line, and pupillary line. That's what we've talked about. You want the incisal plane to parallel the pupillary. You want the central incisors incisal plane to parallel the pupillary line, and you want the incisal plane of the anterior teeth to parallel approximately the lower lip and the gingival line. So gingival line, incisal plane, lower lip should be approximately in the same plane. And also you could most of the time include the maxillary lip. See, the same thing. Pupillary line, gingival line, incisal plane, lower lip in each of these cases. The occlusal plane should extend from the incisal plane, forming a U-shaped arch, just like I was talking about. Should be a U shape and not a big step between the incisal plane and the occlusal plane. See how it, lips versus tooth display. These are just some, you want, again, go with the incisal planes, all the different lips and tooth versus tooth display, but their fundamentals I'm going to talk about. All right, so there are three different types of lips, and I'm talking about lips in repose. Lips in repose. You've got the flat lip, where there's minimum tooth display, but you should always have some tooth display. And so I'd like to see 1 millimeter to 2 of tooth display with lips in repose. We're going to talk in a minute. If the tooth is not, there's no tooth display, or the tooth is, the patient's tooth is less than 11 millimeters, is it from shortness apically in the gingival area, or is it from being too short incisally? Because if you're restoring teeth, you really don't want to cantilever more than about 2 to 3 millimeters of restoration off the end of the tooth. So you have to understand these things and know this about a patient and know how to measure them before you prepare tooth for veneers or crowns. Because if somebody has no tooth display to start with lips in repose, then how much incisal preparation should you do on the tooth? Minimum. You're only going to make the incisal edge flat, but you're going to take the minimum amount of tooth structure, because you don't want to cantilever lithium disilicate, porcelain, whatever restoration you're using, off the end of the tooth more than about 2 to 3 millimeters. If you do, that cantilever makes the restoration more likely to fracture. So this is the first type lip, a flat lip. This is the second type lip, a moderately arched lip. Now, I studied this years ago and published an article on this. I've not seen another one published, but most models have a moderately arched lip. Now, when I'm talking about the type of lip, I'm talking about lips in repose. So the flat lip with lip in repose displays a minimum amount of tooth structure in repose, but it does display some tooth structure. A moderately arched lip displays about half the tooth when the lip's in repose. And most models, as I've studied this for years, have a moderately arched lip. Then you have a maximally arched lip. Now, in 40-something years of practice, I've only seen a few of these in my office. With these patients, they display the entire tooth with the lip in repose. That's a maximally arched lip. So it's not fair when it comes to smiling if you have a maximally arched lip, because all they've got to do is just flex the corners of their mouth a little bit and they're smiling. Whereas if you've got a flat lip, you've got to work at it. So the average lip moves 3 to 7.5 millimeters from repose to full smile. I think I published this article in the early 2000s, and I really studied it back then. So if you've got a maximally arched lip, the lip only moves about 2 to 3 millimeters from lip in repose to full smile. If you've got a flat lip, the lip moves about 7.5 millimeters from lip in repose to full smile. So it moves from here to here is about 6 to 7.5 millimeters, whereas this one probably moves 4 millimeters, the moderately arched lip. And this one, it's just not fair. I've got a flat lip, so I've got to work at it to smile. She just has to kind of flex the corners of her mouth, and she's got a full smile, but the lip is only moving about 3 millimeters from here to here if you have a maximally arched lip. You won't see too many of these people. Now, what would she have? She'd have right on the border of a maximally arched lip. So see, she didn't have to move her lip but about 2 to 3 millimeters to go from lips in repose to full smile. So tooth size. When you're analyzing tooth size, say you measure the teeth and a tooth is 6 millimeters. I'm going to show you some fascinating cases if we get to it this morning on tooth size and things that I've uncovered in my practice with people that have been going to the dentist their whole life, and with this new mode of dental practice, kind of the corporate thing of people just running people through like a herd of cattle, seems like nobody's taken the time to analyze the whole case and decide what is the situation, what really is it. You're not just sticking a veneer or a crown on a tooth, it's a thoughtful restoration, and you're deciding what do you need to do, what's the appropriate restoration, how much tooth should be prepared, all those things. I think that art is being lost. Okay, so this is a pretty ideal smile. You've got near a moderately arched lip, tooth display with a smile, and they're symmetrical. So if you measure this case 10 millimeters long, you've got about 9.5, 10 millimeter width tooth. Let me go back to this. All right, now this tooth is a square tooth. And so in a case like this, if you've got one that's as wide as it is long, they look square. This is a pretty optimum tooth. See, as we said, it's about 11.5 millimeters long, and you'll remember the widths in the beginning, it's about 9.5 millimeters wide. So those are pretty optimum. And the golden proportion of the lateral incisors and the cuspids is pretty ideal. So full smile. What are you looking for in full smile? Well, more of this than this. Now, what about a gummy smile? We're going to talk about that with some cases as we go along. Sometimes you can't get rid of all the gingival display if somebody has a gummy smile. And this is where dentistry at a high level is thoughtful. Say somebody has a gummy smile, you don't want these teeth to be more than 12 millimeters long, period. You don't want them to be more than 12 millimeters long or they look like horse teeth. So there's no issue with somebody being attractive if they have the correct length of teeth, even if they display more than the average amount of gingival tissue. So just remember that. You don't ever want the centrals to be longer than 12 millimeters, but you want the gingival line to be symmetrical, and you want it to be parallel with the incisal plane. I'm going to show you some cases and how I analyzed them as we go on this morning. The incisal edge position of the maxillary anterior teeth with lips in repose. We talked about that. What would this be? This would be, I would call that a moderately arched lip. She displays about half of the tooth with the lips in repose. So how much is her lip going to move apically in a full smile? Probably 2 to 3 millimeters, or maybe 4. The maxillary arched lip, she's near a maxillary arched lip, is only going to move 2 to 3 millimeters. Dominant central incisors is a sexy look. Now you can see she hadn't had a night guard. She sleeps on her left cheek and she's worn the teeth on the right side. So if she's seen me when she was a teenager, she would have had a night guard and her incisal plane would have been symmetrical and ideal. So you can maintain people's incisal plane position their whole life. Be sure you tell your patients, here's a couple of hot tips, tell them the only time their teeth should touch is when they swallow. Go ahead and swallow and feel your teeth touch. Your teeth should not touch as you go through the day. They shouldn't even touch when you chew their food, only when you swallow. When they chew their food, the first few chews of any bite, chew softly, because if there's a rock or a bone in that bite, even rice or beans, and they chomp down, they're going to break a tooth. So if you have tooth wear on the anterior teeth, normally that occurs at night when they're sleeping. People are not going to go through the day doing that, grinding their front teeth. They're going to clench. They can wear the teeth and get abfraction. Remember, abfraction caused from teeth clenching. And you can see the back teeth look like mortar and pestle. Those are teeth clenchers, not grinders. The grinding and the wear of the incisal edges of the anterior teeth occurs at night, most of the time when people are sleeping from bruxism. So get a night guard. Our daughters got night guards when they were 16. I said, wear it the rest of your life. Your teeth will be this length the rest of your life. Tooth size. We talked about that. The average central is 11 millimeters. If it's a small person, it may be 10. Laterals are a little less than that. You want the incisal plane to parallel the lower lip. And then euchromin value. I normally want the ideal shade of women's teeth usually to be a little lighter than men's teeth. Depends on the situation. If you've got an older male, he doesn't want light, even naturally light teeth. He wants more of a natural shade, and I'll show you some cases from one to the other of that. So this is what I want to go through with the patient before we complete the case, and what I do at the consultation appointment is show them other cases I've done, that I've completed. And I have a formal consultation after the exam. And we look at cases, and I say, if my wife or daughters were having their teeth restored in your situation, this is the shade, the euchromin value I would pick. Now, what if you're only restoring the maxillary teeth and not the mandibular teeth? I don't ever, if I'm restoring enough teeth to change the shade. Now, if you're changing the shade, the euchromin value of the teeth in the maxillary arch, you have to restore more teeth. You have to restore 8 to 10 teeth. You can't change the shade if you're restoring 2 teeth or 4 teeth. Do you ever restore 2 teeth or 4 teeth? Sure, all the time. If the shade is pretty close to ideal and the patient is happy with that shade, maybe we bleach the teeth and determine the shade, but you can't change the shade of those teeth if you're only restoring 2 to 4 teeth. If you're changing the shade significantly and want a significantly lighter shade, nothing looks worse than 6 restored anterior teeth and darker posterior teeth. So if you're changing the shade, you've normally got to restore 8 to 10 teeth. All the teeth in the maxillary arch that are displayed when the patient smiles. Do those restorations have to match the lower teeth? No. No. If I'm changing the shade of the maxillary teeth, anterior teeth, I don't even pay any attention to the lower anterior teeth. I make them ideal because usually at most the incisal edge or just the incisal third of the lower teeth is displayed when the patient smiles. And why would you want to match that shade if we don't like that shade to begin with? That's like somebody having a room of wallpaper and something was wrong with this wall, so they fix that wall and match the wallpaper to the other walls. The next year something happens to this wall, they have to change that wallpaper and match it to the other walls. And finally, something happens to this wall and they have to change the wallpaper to that of that wall and match it to the other. And the woman says, you know, I've always hated that wallpaper. Well, you're setting the tone when you restore those maxillary anterior teeth to the ideal shade. Oftentimes people will come back and restore the lower teeth. I'll show you some cases like this if we get to it today. But bottom line is, if you're changing the shade, don't match the lower anterior teeth, because if we're wanting an ideal shade. Gingival line is such a big deal. Oh, I can't wait to get to these cases today. Dentists often do not pay attention to the gingival line, and it just looks like hell when they get to the end, because maybe the teeth look decent, but you got this weird looking gingival line. So that's why I'm such, that's why I have a comprehensive practice. Remember, a comprehensive practice doesn't mean you're doing something to every tooth. It means you're analyzing everything before you do anything definitive. So every patient I see, I do a comprehensive exam, take radiographs of all the teeth, a thorough clinical exam, check the occlusion, oral cancer exam, fillings, take diagnostic photographs, and then have a separate consultation appointment with anybody involved in the finances. So I've got books that I've published on before and after, and I have 1 million PowerPoint cases. We look at those so the patient knows what they're looking at when they look at their photographs and radiographs. Then we look at their radiographs, and the patient should be able to diagnose himself. So you're analyzing the whole thing before you do anything. What if they've got a TMJ problem and you keep their mouth open for an hour and a half or two performing endodontics and a crown on a tooth, and it exacerbates that TMJ problem and you didn't even know about it? Or they have other teeth that are broken down and you could have sedated them and done more things at one time if they want to. This is not selling. We're not selling somebody something. We're informing patients so they can make an informed decision about what, if anything, they want to have done. So the facial skeletal position, this is a Class 2 Division 2. The centrals are rabbited in and the laterals are out. I want to talk about these things. This woman had had a facial pain problem for years because somebody put a lower anterior bridge and they didn't check her in the alert feeding position. Every time she bit together, it distalized her condyle and caused terrible TMJ problem, because that condyle was being shoved into the retrodiscal tissue. So I redid the bridge and the other restorations and moved her out of that rabbited back position, Class 2 Division 2, and checked her in the alert feeding position so that the mandible wasn't being distalized, and got rid of it overnight in the provisional. So there's just a lot to know about this. It's not just putting restorations on teeth. Spacing of the teeth. Do you always fix these diastemas? Not necessarily. Think David Letterman, or different models that have a diastema that can be aesthetic. So you want to discuss those things with teeth. I'll show you a case that I did. I restored this guy's teeth, and he said, don't you think I should keep that attitude with my front teeth, meaning had a space between them? And so when we restored it, we restored the attitude between the front teeth. So don't just take it for granted that the patient wants to change that. Skeletal relationship of the maxilla to the mandible. You want to check the bite. Is it a skeletal issue? You know, it's so interesting to me. I see patients all the time that have TMJ problems, and the dentist sent them to the orthodontist. Why? Ortho doesn't have anything to do with TMJ. Now, ortho, by good orthodontists that are nice people, can cause TMJ problems if the patient is a grinder, because they get the teeth straight but not necessarily the occlusion right. TMJ is caused from, most time, from malocclusion on a patient that grinds their teeth. Stress on an imbalanced system. You'll see a lot of people with malocclusions that don't have TMJ because they don't do what? They don't grind their teeth. It doesn't come from chewing, it comes from clenching. So if you're clenching on an imbalanced system, that's like jogging 10 miles a day on a leg shorter than the other. So orthodontics is not the answer to solve TMJ problems. You first get the occlusion right. So when the patient closes in the you put the patient into centric relation, and they close into centric occlusion. Centric relation occlusion splits. There's different things. You can watch my videos on treating TMJ. I'm not trying to get TMJ business. I'm just saying orthodontics is absolutely not the answer if somebody has myofascial pain or a TMJ problem. That's a whole nother discussion. The lips of the frame and the teeth and the gingiva are the pictures. So here's the frame and the teeth. This is pretty much ideal. Some gingival display and display the whole teeth. I just hope she's got a night guard, because if she's not and she sleeps on her left cheek, she's going to wear the incisal plane on the right side, on the opposite side that she sleeps on. This woman has a gummy smile, but she's still attractive. What we'd want to do is measure those teeth, and I mean, it just depends on what she felt about it. That's not an unattractive smile. You don't need to fix everything, but I would give her a night guard because she didn't want those teeth to get any shorter. You can tell she spends a lot of time on this cheek. You see how she's worn those teeth? So with those teeth being short already and significant gingival display, that's what is not attractive, are little bitty teeth with a gummy smile. We'll talk about that in a minute. So what do you think about these? That's pretty ideal, Lady Di. That's pretty ideal. Centrals are the longest teeth. Incisal plane parallels the lower lip. Incisal plane of the centrals is parallel to the lower lip, the gingival line, and the pupillary line. That's pretty much ideal. What type of smile does she have? Well, about a moderately arched smile. Moderately arched lip. But when she smiles, how much is that lip moving? Probably 4 millimeters, and she displays the teeth. The incisal plane is good. Elizabeth Hurley, I hope she has a night guard because her incisal plane is good right there. What type of arched lip does she have? Moderately arched. Displays about half the tooth. So when she smiles, the lip's only moving probably 3 millimeters to get into full smile, but incisal plane parallels the lower lip, incisal plane of the centrals parallels the pupillary line, gingival line should parallel the incisal plane of the maxillary anterior teeth. She's got a flat lip, so she's got to move her lip probably 6 to 7 millimeters to get into a full smile. But again, the incisal plane is good, length of teeth looks good. She's got a pretty flat lip and probably short teeth. So we're going to talk about how do you decide what you want to do. Delayed passive eruption, I'm not going to go into that now. I'll talk about that in a moment. She's got a flat lip, so the lip's moving probably 6 to 7 millimeters to full smile. She's got a near maximally arched lip, would you agree? Most of the tooth is displayed with the lips in repose. So when she goes to full smile, she's probably moving 3 millimeters, moving the lip 3 millimeters. She's got a moderately arched lip, and she's got a gummy smile. So what if those teeth were only, say, 7-8 millimeters long? Then you might want to consider moving the gum, periodontal crown lengthening. Now remember, periodontal crown lengthening normally involves bone removal, alveolar process removal, as well as gingivectomy, because you want the gingival line to be 3 millimeters from the alveolar crest. So if you moved the gingival line 2 to 3 millimeters apically, you want to be sure that the alveolar crest is 3 millimeters from that new gingival line. Gummy smile. So again, we'd measure the teeth, and if you don't want to cantilever more than about 2 to 3 millimeters, ideally off the end of the central incisor, because it's a cantilever and they're more likely to fracture. So we've got probably a moderately arched lip, flat lip, or it may be a moderately arched lip with worn teeth. So what are you going to do if somebody seems to have short teeth? You're going to measure the teeth, number one. What's the length? It's, say, 7 millimeters. Then you've got to decide, where is the shortage? Is it gingival shortage or incisal shortage? So it's like working a Rubik's Cube. You've got to have all these numbers going on in your head. Say it was 7 millimeters, and she also had a gummy smile. Well, you're gonna get most of the. You're going to take a periapical radiograph and determine the distance from the CEJ to the incisal edge. I'm going to show you how to do that here in just a moment with a case. So that's when we're determining, do we need to gain length incisally or gingivally, or both. And you don't want it to be more than about 2 to 3 millimeters off the incisal edge. So what do you see here? Probably worn and chipped teeth and kind of a funky alignment between the gingival line and the incisal plane. So what is aesthetically pleasing? You've got to determine that too. What's the patient wanting? In every seminar I've ever given, I say you've got to have technical expertise, but beyond that, it's about the conversation. That's why I want a formal consultation with almost every patient I see to talk about things. Just, where are we going with this? What's your objective? Why would you want to restore these teeth with the current shade of the patient's teeth if they didn't like the shade of their anterior teeth? Why would you want to restore somebody's kitchen if their objective was to knock out walls and change the rooms of the house? I want to know where we're going before we start. That's why I have a comprehensive exam and separate consultation with every patient, with diagnostic photographs of their teeth, the books, my PowerPoint cases, and we decide together where we're going. I'm not trying to talk them into something, but we want to know where we're going. So what do you think about these? See, his midline is way off, but he's done okay for himself. She's got short teeth. You know, he sleeps on his left cheek and has worn these teeth. She sleeps on her left cheek and worn these. She's got a gingival discrepancy right here. We're going to talk about how I solve those. You know, she's got, that's not a problem with a gummy smile as long as the teeth are of normal length. Gingival display is not an aesthetic as long as the teeth are of normal length and the gingival line is symmetrical. See, this is big gingival line, incisal plane, discrepancy. I'll show you how I change that. You know, she's got some worn chipped teeth. sleeps on her right cheek, and has worn these teeth. A lot of gingival discrepancy, and so you've got to decide if you want to correct it. If somebody is displaying the gingiva when they smile, do you want to perform gingival grafting or periodontal crown lengthening? Periodontal crown lengthening is 100 times easier than grafting. Grafting is a trick if you're going to try to even things up here. You know, especially if somebody's got a crown on a tooth, you really can't do it. You know, pretty good. Incisal plane, parallel lower lip. So I tell patients I'm really a home remodeler. I'm not a home builder, I'm a home remodeler. And so before I remodel your house, there's so many things to go through. And so much of it these days gets down to finances. Sometimes I feel like I'm more of a banker than a dentist because I see the things that could be done ideally. I don't talk people into things, but in my practice, I'm not going to do anything that I'm not happy with. I'm not going to patch people up because the patch up breaks down and then you're a bad dentist, because even if the patient wanted you to patch them up, they're going to forget you talked about that, so I don't patch them up. Whatever we do, even if we do it in stages, I want to fix whatever we're treating. I put this photo in just because I always like that photo. I've used that in seminars for 40 years, and I just like the look of it.
About 15 minutes to go to 1 hour.
Okay. There are a lot of things, so we're kind of getting near the end of our time. We're going to talk about creating gingival ponic, different things to talk about with replacing missing maxillary anterior teeth, implants versus fixed bridges. Like I said, this is a 2-day seminar, so I'm just giving you the fundamentals. I don't replace missing maxillary anterior teeth if there's gingival display when the patient smiles. If gingiva is displayed when the patient smiles, I'd rather put fixed bridges in because I can control the gingival line. This is a Maryland bridge I placed with this lady because it kept me from having to prepare the teeth. And I don't look at a Maryland bridge as a forever restoration. And the patient does not want to bite with their maxillary anterior teeth if they've got a Maryland bridge. So this is implants and fixed bridges, full crowns. When you do a full crown versus a veneer, or if there's a lot of tooth missing, I'm going to place a full crown just for retention from the palatal side. Okay, this is going to be, I think, interesting. This woman's an attorney, and someone had placed veneers on her lateral incisors, and she hated them. Well, what do you see now that we've talked about what we've talked about with this case? Number one, the veneers are dark, but number two, the gingival line there is asymmetrical. See this, the gingival line should be parallel to the incisal plane. She's got a beautiful tooth shade, but the veneers don't match the adjacent teeth, and this gingival line is not good. Remember, you want the lateral incisor gingival line to be a little coronal to the adjacent teeth. So this one's pretty good. So I've done a periodontal crown lengthening here. Now remember, you first do a gingivectomy to determine the new gingival position. Then you reflect the flap, and you want to be sure that the alveolar crest is 3 millimeters from the new gingival line. The excellent periodontist in Dallas, Pat Allen, taught me this technique, so I want to give him credit. But a lot of people will just do a gingivectomy. Well, if you do, and you've not created a proper biologic width, meaning 3 millimeters from the alveolar crest to the new gingival line, the gingiva is going to regrow and reestablish that biologic width, and it'll grow over the restoration. You'll have inflamed red gingival tissue. So this is before and after. I replaced the lateral incisor veneers, and then I've replaced this veneer with this veneer at the proper gingival line. So this is before and after. You can see the gingival line is right. It's subtle, but I see a lot of picky patients, and I'm really picky. So I said, I can outpick you. How good do you want this? Because I'm not going to do it if I can't get it right. So this is a good look. You know, now our gingival line's right, our lateral incisor is right. That's after. So she was happy and I was happy. And that's a big part of my practice is I want to be happy with it. I'm not going to do it if I'm not happy with it. I'd rather do less and do it right than try to do a lot and do it wrong. What about this guy? His mother had him come in because the dentist had put 2 crowns on the front teeth. And I see this all the time. I'm not using the word I'm thinking about. People are just, dentists are just processing people. Where did that come from? They don't know how, I guess, to analyze the whole thing. So they put 2 crowns on his front teeth. And the mother said, he looks like a goober. I agree. You know, they're not looking at the big picture. See the discrepancy between the 2 teeth? I said, you know, we knew what it was. So I'm marking where I want the new gingival line to be. So you create the gingival line first and then adapt the alveolar crest to the gingival line because you want the alveolar crest to be 3 millimeters from the new gingival line. I've got a whole seminar on this. So I first did the gingivectomy, then I did the ostectomy. Okay, so I've moved see, this is tooth structure. I've moved the gingival line up, and this is before and after. See, now we've got gingival line is symmetrical to the incisal plane. Okay. I always interview patients before I examine them, say, what do you not like? She didn't like the gingival line, and she didn't like these fat laterals. That's what she called them. And I agree. You know, she's a beautiful girl, but she's got, the laterals are not symmetrical, they're too wide, and the gingival line is not symmetrical. So I first mark it on a model and trim it and then wax it up. I always want to know where it's going to end before I start. I'm doing a periodontal crown lengthening. Now remember, that's not just a gingivectomy. The alveolar crest, the bone line has got to be 3 millimeters from the new gingival line. So if measuring from here to here is 9 millimeters, the new alveolar crest has got to be what, 12 millimeters? And if you don't do that, that gum will regrow over the restoration. It'll look like hell. I'm removing bone. So here's the new gingival line. If that's 9, the alveolar crest should be 12. Trust it, it works. So what we've done to make these teeth thinner, we veneered the other teeth because I can't just make them thinner. If I do, I'll have spaces in here. You've got to take up that space with the adjacent teeth. So You know, a lot of times people think, oh my gosh, if you go see Dr. Cutbirth, it's going to be really expensive. Well, I don't care. You know, we don't have to do this. We can just do a night guard. But if you want to fix it, I tell people, I will fix it. You're going to have, you may need more procedures than the average dentist would do because they're probably just fixing a tooth. I'm looking at the picture because you don't care if you've got a good tooth. You want a gorgeous smile. So now the teeth are the normal width. See, they're not fat. They're the normal width. Gingival line is good. Gorgeous.
We have about 5 minutes until an hour.
Okay, we're going to run over a little bit. Okay, what about this case? Now, I'm not sticking to the hour. I may be an hour and 15 minutes, an hour and a half. If you need to go somewhere, go ahead and go. But this is too important not to go through. What do you see?
You can really go as long as you want. Yeah.
Okay. So I'm just entertaining myself, so y'all can stay as long as you want. Look, the gingival line slants this way, the incisal plane slants this way, the pupillary line is right here. Everything's off. So this woman was from a town about 3 hours from here, and I'd restored her sister, and her dentist was going to replace these two teeth. What is that? What is that? What if you replace those two teeth and match this over here? I said, go back and see him if that's what you want to do and replace those two teeth. She said, so you won't do that? I said, hell no. Because I want you to have an attractive smile, and it's about me, it's not about you. I can't have you walking around out there with something I did that looks terrible. And that's what that's going to look like. You can't make this look good because if you match these teeth, it's not going to look good. So what have I got to do? I've got to square up the gingival line and the incisal plane and change these teeth. I'm not trying to get my hand in her pocket. I'm not. I'm just not going to do something that is not something I'm proud of. I want to keep it as light as I can. But that I don't want to go to work if I've got to do that every day. So the first thing I wanted to do was square up the gingival line. Put provisionals on these two teeth and created an ideal incisal plane parallel to the pupillary line. So I can square up the incisal plane, the gingival line, and the pupillary line. Again, incisal plane, gingival line, pupillary line are all parallel. Now I've got to match the incisal plane of these adjacent teeth to the gingival line and the pupillary line. So this is after I restored her. Now the lower incisal plane does not have to be parallel to the maxillary incisal plane. You know, as long as you've got good function, centric relation occlusion, you're okay. So you'll notice in this case, this is the point I was making a while ago. A gingival display is not necessarily anesthetic. It's not necessarily anesthetic as long as the teeth are the proper length. Now, if the teeth are little tiny teeth and you've got a lot of gum, that looks like a cutesy smile. This is good. So this is her before. See how it's all squared up? So these cases are what get me out of bed every morning, you know, to fix it. I like to fix it. I know how to fix it. I can fix anything. Now, I'll have some patients go running out of my office going, oh, that's just too much. I don't want to do that. Well, to fix this, do you see what I'm saying? That's what you have to do to fix it. What if I'd said, okay, I'll just put 2 crowns on those 2 teeth. If I do that, I'm just taking somebody's money to make a living. and that's not enough for me. I want to do this to get it right. There has to be some place that people can go and really get it fixed correctly. So, interestingly, what happened to her after we did this, she had a menial job with a hotel company, and she'd had it for 10 years. After we did this, she became over 500 people doing the same job at the hotel. Now, what about this case? This woman had been going to the dentist all of her life, several different dentists. And she said, I hate my teeth. I said, what do you hate about them? She said, they're so short. And she said, nobody knows what to do about it. Well, I'm no smarter than anybody else, but I've got a lot of training in surgery and restorative and occlusion and facial pain. And so if you know what you're looking at, this is delayed passive eruption. See, so she's got a pretty good length as far as lips in repose. She's got tooth display. But you want to find out if there's tooth up here under the gum that's just not erupted. So the average central, you remember, is 11 millimeters, 10 to 11. Smaller woman, it might be 10. These are 6. So you take a periapical radiograph and measure from the CEJ to the incisal edge. Guess what that length was? 11 millimeters. All these years it's been up there, but nobody knew what it was. And if you know what it is, it's like smoking a cigarette and drinking a martini. It's just like, yeah, that's delayed passive eruption. So I did the periodontal crown lengthening. Remember, the first thing you do is the gingivectomy. Then you do the ostectomy, because the new alveolar crest has to be 3 millimeters from the new gingival line. Thank you, Dr. Pat Allen, for teaching me that. And I can't tell you how many cases I see come into my office that, is anybody trained anymore? I mean, they just don't seem to know how to look at the big picture and get the result that's optimum, because they'll do a gingivectomy or put a crown on that tooth like those others, or not recognize something like this. So this is periodontal crown lengthening, and then I veneered the teeth back as far as you can see. So guess what happened to her 6 months after we did this? She got married. So, you know, think about going through life like this or like this. Now, what about this guy? He was from a different state, and his dentist did examine him. He had some bad habits and said, we're going to have to take out all your teeth and put in dentures. And the mom just panicked and said, no, he's only 25. You can't do that. So this dentist had been to some seminars I'd given when I had my teaching center in Dallas. He said, well, there's this guy in Texas that may be able to fix it, because it seems like he can fix anything. So they flew down, and he had decay all over the place, just bad habits. All between the back teeth. So he is a full mouth reconstruction if you want to save the teeth. That's why I don't know how you people practice without a comprehensive exam and a separate consultation to just discuss it so everybody knows what's going on, so there's no question when you get to the end. Number one, you know you've taken care of everything, you've discussed it all, and you fix everything that you want to fix in the process, kind of like remodeling a house. Know where you're going before you do any definitive work. That to me is so basic. I don't know how you practice any other way, but from what I can tell, people just see a patient in their office and they just treat them, and they're not examining the rest of the teeth, they're not checking the occlusion, they don't see if they've got TMJ problems, they're just processing people. Well, you're not bad people, but how boring does that sound to me to practice like that? And you're going to end up with a lot of miscommunication. So the first thing I had to do was get above the decay and below the decay with periodontal crown lengthening. Remember, you do the gingivectomy first, then you reflect the tissue and do an ostectomy so that the bone line or the alveolar crest is 3 millimeters from the gum line. And see, I'm below the decay with the gingivectomy. Now, if you do just a gingivectomy and not the ostectomy, the gingival tissue is going to grow back over your restorations. It's going to look like hell because the gums are going to be red, inflamed, bleeding, and just yuck. This after a week of healing. See, I'm below the decay and above the decay. This is a young guy, and he wanted lighter teeth. The veneers on the anterior teeth, crowns on the posterior teeth. What kind of lip does he have? Moderately arched? You know, but this guy's got a life after that. This is a case where she didn't like her teeth. She said, every time I go to the dentist, I have a problem. And she's had big fillings in the posterior teeth. But in her case, she had a reasonably good shade down here, so we just did a little bonding on the incisal edge, bleached them, and veneered the maxillary anterior teeth, corrected the incisal plane. So incisal plane, gingival line, pupillary line, lower lip line. You know, it's got a good look. This guy, his mother-in-law actually sent him in. And he had a dark tooth here. He was about to get married. And she said he got short teeth and got that dark tooth. So he does have, I'm not giving a periodontal crown lengthening course today. I'm just talking about skull drill. How do you look at these cases? So those teeth were about 7.5, 8 millimeters. So I've done crown lengthening and veneered just the 4 anterior teeth and bleached the adjacent teeth because he had a decent shade. But this is after periodontal crown lengthening and veneers on the 4 maxillary anterior teeth. Though we did endodontics and internally bleached this tooth before we veneered it. What about this woman? She'd been in the Army and just had a roller coaster incisal plane. And she said, nobody knows what to do with it. Well, you know, number one, now you know the fundamentals. What are you going to do? You're going to match the incisal plane with the gingival line, the pupillary line, and the lower lip. And so I wax it up ahead of time so I know I can do it if I can wax it up. So here's the waxed up model. So we veneered maxillary anterior teeth. We wanted to change the shade, so we're going back to at least the first bicuspid, and then the lower anterior teeth back to the first bicuspid. Incisal plane, symmetrical to the even of the lower lip, flat incisal plane of the lower anterior teeth. If you change the shade, remember you've got to go at least normally to the first bicuspid, sometimes to the second bicuspid. You want all the teeth that are displayed in the smile to be veneered, because nothing looks worse than 4 to 6 anterior teeth that are light and dark posterior teeth. I can't live with that. I'm not going to do that. I'd rather them go somewhere else and let somebody else do it, because I don't want my name on that work. Restored, this is lower teeth, crowns on the bicuspids, veneers on the anterior teeth. It's interesting to see how these people's demeanor changes, especially women, once you get their anterior teeth fixed, and they have a great smile. This woman, nice lady, just tetracycline stain, some funky gums, incisal plane. What she got? A moderately arched lip. So I'm not going through all the things I did with these cases. You can even change some moderate crowding with veneering. So I wax it up ahead of time. You can watch my video on how to wax models and figure out where you're going. So I want to know what it's going to look like before I start. I don't ever start anything until I've waxed it up. So I need to do periodontal crown lengthening on that tooth to get symmetrical look. So this is her before and after. If you think about this person going through life like that or like that, I rest my case. I'd rather do a few of these cases and get it right than patch up 100 cases and just make a living. I mean, I guess somebody has to do that, but it's not going to be me. I want to fix it. I want to be as inexpensive as I can. But what did that guy say? I'm easy to please. I just like the best of everything. I want to use the best laboratory technician, use the best technique, come up with the best product. I think of every case, I pretend this is the last case I'll ever do, and I want to go out with a bang. And I want them to be crying when they leave my office because it looks so good. This guy, now this is a different thing. He's a U.S. ambassador. He said, Steve, I've always hated my teeth. Just spaces, short teeth. So we had to go through. I said, okay, I can do it. But we need to do some Invisalign first. We do a lot of Invisalign because I love it because the computer tells you what to do. And so I need to, whenever you've got spaces between the teeth, remember, you've got to either make them narrow enough that you can place adjacent restorations and close the teeth, or wide enough that you can put a tooth in there, a Pontic or an implant. So see, we've got spaces, discolored teeth. So I've either got to make these spaces wide enough for an implant or a bridge, or close enough together that we can place veneers or crowns. See, same thing. They've either got to be wide enough for a tooth, for an implant or a bridge, or close enough together that you can place adjacent restorations and close the space. Tooth display with lips in repose. So what time is it?
10:13.
Okay. So I'll show you a couple of wild cases. Mm-hmm. So this person said, I will not undergo orthodontics. We'd restored his wife, but he said, I want to restore these. He was an international businessman. So I waxed it up ahead of time to see I could do it. And whenever you prep teeth this dramatically, there's always a chance you'll have to do endodontics on them. You'd rather do some ortho, but it just was not in the cards for this guy. He was traveling internationally all the time, so I did the teeth preps and created this Polyvinyl's like saying jig, so I'd know how much to reduce the teeth, and I don't have to think about it. I reduce them down to the jig. I think that's the only tooth I had to do endo on. And he said, I want my teeth to have an attitude, meaning the space between them. So we did. I did this case with Willie Geller, the great technician in Switzerland that sadly just passed away last December. And we worked together for about 15 years. He was fantastic. So I could move this back, get the facial, palatal alignment, still kept a little attitude. This nice gentleman had worn his teeth, worn the posterior teeth. You can see all the, so we first increased his vertical dimension. If you're changing, if you need more space, or if people have worn their teeth, then sometimes you need to increase vertical dimension, especially if the incisal plane, the occlusal plane look like a roller coaster. Then you've got to open it up, and it makes it easier to restore the teeth with proper incisal and occlusal planes. I'm not going to go into all of that. We're just talking about the fundamentals today. So these are restorations on his teeth. This person had a melogenesis imperfecta, and she'd been to dental school, and they said, we don't know what to do with it. So she came to see me, and I said, I can fix anything. So I increased her vertical to have more space where she'd worn the teeth, waxed it up. Then I know I can do it. Bridges, crowns. And that I did this probably 15 years ago. She's still a patient in our practice. Everything's held up. Severe wear. So in a lot of these cases, I'll increase the vertical if they've worn a lot of tooth. Now, how do you know if somebody has lost vertical dimension? They have thin lips, reverse curve of the lip. They've often got angular cheilitis, chafing in the corners of the mouth, horizontal lines in the face. The chin starts to come forward. Those people have lost vertical dimension. And so I'm going to give them back the vertical dimension. See, no tooth display with lips in repose. So I've restored, this is her before. Just kind of a patchwork quilt. How many people do you see like that? Leaky fillings because of that mode we've got of just patching people up. I'm not saying somebody's bad for doing it. I'm just saying I'm not going to do it because it doesn't interest me, and you don't have a long-lasting restoration. I did this probably 15 years ago, and she's still in my practice, and everything is just exactly the way it was. So I'm increasing vertical, waxing it up.
Steve, do you want to talk about, some people said you should never increase vertical?
Yeah, that's a good point. Sharon's saying it was said by a famous dentist years ago, you should never increase vertical dimension. Well, sometimes you have to, and I've increased it 100 times over the years and never had an issue. So sometimes you have to, yeah.
They had the vertical.
Yeah, yeah. So if you see those signs of thin lips, downturned corners of the smile, horizontal lines in the place, and they've got that compacted look, that's an increase of vertical dimension, and you want to increase them. If, I get finances, that's always, not always, but so often an issue, especially today, because to do these things, you're doing more things than other dentists are doing, and so it's probably going to be a more expensive case, and you may have to live with that reputation that you're more expensive. It's not necessarily that the things are more expensive. You're doing more things, and you're using the best of everything. You're not using a cheap lab. You're using a master lab technician, and so it's just life. What can you say? So this is her before and after. If you're increasing vertical dimension, you've got to place full crowns on at least the maxillary arch, and usually you're placing full crowns on the maxillary and mandibular arch. I'm not going to go into why in this seminar, because I could be here all day talking about cases that were increasing verticals. This are upper and lower. So now we've got tooth display with lips in repose, flat, lower incisal plane. Wow. Now this is after increasing vertical. See the horizontal lines in her face, downturned corners of the mouth, thin lips. Now, okay, now end on this case. This woman is one I did with ceramist Willie Geller, and she was a prominent woman, but her teeth had just bad. And she said, I want to fix my teeth, but I don't want to lose my look overall. So I talked with Mr. Geller and told him what we were trying to do. She didn't want ortho, so I waxed it up ahead of time. But she still wanted her basic overall look. So this is the final result. It's so sad for a lot of us that Willie Geller has passed away, because he was so creative. You never knew what you were going to get back. This is her final restoration. This is her before and after. So these are, when I first got this back, I thought, oh my gosh, she's going to hate it. She adored it. She loved it, because it created, it kept the overall look, but made it healthy. Even the incisal, protrusive and eccentric movements were ideal. Lips in repose. Okay, so I think that's a good place to stop with this. So remember, fundamentals of aesthetics, if I had to put it on one sheet, it would be first determine the optimum length of the central incisors, and that's normally going to be 11 millimeters. Then see if there's what type of lip does the patient have? Flat, moderately arched, or maximally arched? Is there tooth display with lips in repose? There always should be tooth display with lips in repose. Remember, with a flat lip, you're not going to have as much tooth display. With a moderately arched, you're going to display about half a tooth, and with a maximally arched, they're going to display the whole tooth. Then decide, how does the patient feel about their anterior teeth? Do they want to change anything? They're not going to die if they don't, because you've got restorative dentistry, which is the functional part. And most thinking people that can afford it want to have functional teeth. They don't want to have a bunch of big old leaky fillings. They don't want to have cracked teeth, that type thing. But the aesthetics is usually optional. And so then determine what type of lip and how do the teeth relate to that lip. And so after you've determined the length of the teeth and the lip type, then decide, if it's short teeth, if they've worn the teeth, you may want to add some length to the incisal edge. If they have delayed passive eruption, or you need to do a periodontal crown length, you've got to determine, do you want to gain length from the gingival part of the tooth or from the incisal part? And you don't want to cantilever more than about 2 or 3 millimeters off the incisal part, especially if it's a veneer, because they've got too much cantilever and they bite on that. I tell patients, even with natural teeth, you shouldn't bite anything harder than a tuna fish sandwich or a hamburger with your anterior teeth, because the leverage is bad. the shear force. And we see 2 or 3 people a week that have chipped natural teeth, biting something, pizza, corn on the cob, apples, anything hard with the front teeth, because the muscles are so strong, they don't know their own strength, and they bite that, and you chip those teeth, especially if the person has not had a night guard and they've sharpened the incisal edge of the maxillary and mandibular anterior teeth. So go through those checklists. You can watch this. We'll have this on YouTube or Dentistry Master Classes. And both of those, and you can review this. So every time you have a case, go through and decide what you're going to do. Dentistry is fun, but it's not for the faint of heart if you really want to get it right. So I'm glad you were with us. That's dentistrymasterclasses.com. These techniques work, and they work every time. That's the Dental Minute. These techniques work, and they work every time.
Any questions?
Have a good weekend.
Okay.
A couple comments, just
What?
questions?
What do we have, comments or questions?
No questions.
Okay,
We had quite a bit of people watching, so.
good. Here we go.